Okay, so I hope you all can see my screen now. We are just gonna be live in a moment. Yes, we are live now also. So let's start now, guys. So this is going to be the season 3, and we are going to discuss complications of spine regenerative procedures. So this is something which we have been discussing through the last few weeks. I hope you all can see my screen, full screen. Please type yes.
Yes, they can see it.
Okay, great. So let's begin. So yes, so pain medicine world over has got diverse issues and variable standards. So different learning requirements are there, and as a result, there are different offerings. Money and time are important factors which prevent physicians getting updated. And as a result, and these are difficulties. To overcome these difficulties, Mumbai Pain School is an initiative of Panisha Spine Wellness and Pain Relief Center. We are using online media like Facebook, Instagram, Twitter to create awareness and teach and online learning, on-demand videos and training. This is the hallmark of our education. We have got both free and paid content which we are providing. In addition, we have conducted lots of hands-on workshops. We are fortunate to have received help from expert faculties all over the world. It's said that the best teachers, they teach from the heart and not from the book. Journal club it's nothing, it's just a club. The only difference being that here we critically evaluate recent academic literature which is based on a defined subject. Audience and attendee participation is extremely critical, so I will encourage all of you to participate and ask questions. If any, comment suggestions are all welcome. It is definitely tough to be regular, but we have to be regular. Even Harrison was regular with his journal club, and the purpose was critical evaluation of academic literature. I will request the speakers to stick to the timelines. Healthy skepticism or praise is most welcome. This is a bit about me. I think you already know most of the stuff, but today we have with us Dr. Sandeep Khuba, who is additional professor in Department of Anaesthesiology at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. And his area of interest is pain medicine. He's got multiple publications to his credit. So without wasting much time, I will like to now hand over the mic to Dr. Sanjog. Dr. Sandeep is here with us. I'd like you to just unmute yourself, say hi to all of us. Sir, I've made you the co-host.
Thank you, Sidharth. Am I audible?
Yes, sir. Yes, sir. You're audible, sir.
Okay, thank you. Thank you for inviting me to this academic program of yours. It's really interesting to see the discussion regarding pain medicine. I'm happy to be part of this. Thank you very much, Sidharth. I hope we are going to have a nice discussion on these two papers.
Yes, great, sir. Dr. Sanjog, can you put up your CV slide?
Yes.
So I will introduce Dr. Sanjog. He's done his DNB Anesthesiology. After that, he's done his fellowship of pain medicine. Also done his FIPM. He's a consultant interventional spine and pain physician at Sainath Hospital, Sahyadri Hospital, and City Nursing Home in Pune. He's the director of Jivisha Pain Management Center in Pune, and he's also the executive committee member of Pune chapter of the ISP, that is the Society for Study of Pain in Pune. His area of interest is MSK ultrasound, spine endoscopy, and regenerative medicine. He's got 5 publications and he's been faculty in national pain conferences. He's an avid traveler and explorer. So over to you, Dr. Sanjog, for the first paper.
Thank you, sir. Thank you, sir, for the introduction. So I will straight away go to the today's article that we are going to discuss today.
Yes, we can see the slides.
Yeah. So the title of today's article that we're going to discuss today is Risks of Intradiscal Orthobiologic Injections, a review of literature and a case series presentation. So this was an article which was published in International Journal of Spine Surgery in September 2021. It was authored by Marine Jerome et al. And all the authors belong to various medical colleges and hospitals of New York, like the Regenerative Sports Care Institute, Hospital for Special Surgery, and Will Cornell Medical College. Now, lower back pain, as we know, is a leading cause of disability with a large associated socio-economic burden, which comes not only from the treatment part of this condition, but also because of the loss of days and months that we see in the patients who are suffering from lower back pain. Now, in patients of lower back pain, the disruption of intervertebral discs accounts for approximately 22% of the back pain cases. Now, intervertebral disc, we know, is a unique structure. We know that it has two parts. The central part, jelly-like part with high water content, is nucleus pulposus, and the outer thick part is the annulus fibrosus, which has a particular glycosamminoglycan to collagen ratio. But the anatomic and molecular structure of this intervertebral disc makes it susceptible to injury via the supraphysiological mechanical load. And second most important part is that these discs are poorly vascularized, because of which the microenvironment within the disc is very hypoxic and acidic, and therefore it has an inherent it has a diminished inherent healing ability once injured or degenerated. Now, historically, many treatments have been tried for these intervertebral disc disruption conditions, like the physical therapy, epidural steroid injections, variety of intradiscal injections, denervation of the annulus, that is bicusplasty, and surgical intervention. More recently, animal models have shown promise using biologic materials, including a variety of individual growth factors, platelet plasma, and mesenchymal signaling cell preparations to improve three things: water content, disc height, and cell proliferation in the degenerated IVDs. Now, in 2019, the American Society of Interventional Pain Physicians, they actually included these intradiscal PRP and mesenchymal stem cell injections in the practice guidelines, and they demonstrated that they have a level 3 evidence. This was further supported by a consensus statement published by the American Society of Interventional Pain Physicians in 2020 regarding the evidence-based use of bone marrow concentrate for musculoskeletal disorders. Now, the purpose of this review is that we have seen many studies which are coming up, which are telling us about the various benefits of intradiscal, these orthobiologic use. But the purpose of this review is to catalog the published complications following these intradiscal injections, and they have also presented a case series of previously unpublished cases, and also review the safety considerations as well as mitigation strategies to optimize the patient safety when performing such procedures. In the methodology, a literature review was performed mainly from the databases of PubMed and Cochrane reviews, and the search terms which were used were intervertebral discs, stem cells, bone marrow, platelet plasma, or regenerative medicine. Specifically in the patients in the human species, they've used the filter of human species to identify the relevant studies in these two databases. Now, in inclusion criteria, all the studies involving any form of autologous mesenchymal stromal cells injected percutaneously into the lumbar intervertebral discs in humans were included in this study. Now, in the exclusion criteria, studies using the biologics to augment surgery or animal studies or unrelated papers were excluded. Now, in addition to this review of the literature for identification of previously reported complications, they also presented 3 cases known to a single private interventional sports and spine practitioner. These cases were reviewed for patient characteristics, type of complications, injected, laboratory values, treatments, and outcomes. So after all the search for the review articles, in all, 142 articles were identified, 140 from the PubMed and 2 from the Cochrane review. Now, there were some 6 articles which were identified through other sources. So in all, there were 148 records after removing the duplicates. Now, out of these 148, 129 records were excluded because either they were using allogenic substances, they were using IV adipose mesenchymal stem cells, unrelated topics, or they were done in the animals. So in all, out of 148, only 19 studies were included in this review. Out of these 19 studies, 11 studies used actually bone marrow mesenchymal or bone marrow concentrate or mesenchymal signaling cells as the injected. Out of these 11 studies, 3 studies actually use the same cohort of patients. And out of 19, 8 studies use the PRP injections. And out of these 8 studies, 2 studies actually use the same cohort. These are the results of the studies which actually use the bone marrow concentrates or bone marrow derived mesenchymal stem cells. So here we can actually see all the studies are either the case series or it is one of the studies a case, basically is a case report. So there are no randomized controlled trials or meta-analysis, something like this. So the sample size that we can see here is very low sample size, only 10 or 5 or 26. So the sample sizes are also very small. Now, if you look at the mode of implantation in these studies, there is no uniformity. Some are injecting 3 ml, some are injecting 4 ml. So there is no uniformity in the methodology of these studies. If you look at the period of follow-ups, then they range from 6 months to around 6 years. Now, we'll not look at the clinical outcome because we are focusing only on the side effect profile of these injections. So there were 2 studies which actually identified these, or they actually published these side effects or adverse effects or complications following these injections. One was the case report by Subhash et al. In 2012, which reported the occurrence of spondylodiscitis following these injected. The disc involved was L3-4, and there was epidural abscess and cauda equina syndrome in that patient. One more case series published by Contino et al. In 2017. They actually reported not an infection, but a case of herniated disc 3 months after the injections. So many of these studies actually reported discomfort or post-procedural pain period of 1 to 2 weeks post this procedure, which actually resolved spontaneously. Many of these studies also reported, they gave the percentages of the patients who actually finally went for the surgeries. So if you look at the studies, only one of the study, which was a case report, which reported the incidence of discitis. Now from here starts the cases which actually injected the platelet-rich plasma into the discs. Now again, we can see there, these are all the case series. There are no RCTs. Again, in the methodology, the amount of volume injected ranges from 1.5 ml to 4 ml. The follow-up period ranges from 6 months to 6 years. So there was one case series published in 2016 by Levy et al., which mentioned about a pain exacerbation actually 1 month after the injected, but it was not related to the discitis. There was another case report published in 2019 by Betty et al., which actually reported the incidence of development of discitis following the injection. This is one of the study, actually, this is very interesting. Published by Kirshner et al. In 2016. You can see the sample size. The sample size is quite good. They did cases in 86 patients, but you can see the clinical outcome. The 91% of the patients with excellent pain reduction, but they did not report any of the side effects. So very difficult to comment on these studies. Now coming to the cases. So actually there were 3 cases. There were incidents of discitis or discitis-like condition post-injection in these 3 cases, which are included in this review article. In these 3 cases, the first case was a 55 years old male who had no history of any prior surgery. He had taken a methylprednisolone dose pack 3 months prior, so oral methylprednisolone he took. There is incidence or there is history of lumbar facet joint injection with reginokine some 2 to 3 years back. Patient actually came and he was offered intradiscal BMC injection. He received that injection. He received also IV antibiotics before the injection. There were addition of antibiotic in the contrast also. 500 mics of gentamicin was added. The discs which were targeted were L4-5 and L5-S1. And post injection, this patient developed severe pain, and the level which was affected was L5-S1. We can see his MRI. This is the MRI of this patient. You can see the edema in end plate edema here at the level of the L5-S1. We can also see the extension of this edema into the soft tissues in the paraspinal space. This was how the procedure done: needle inside the disc and they injected. This was also combined with the injection of BMC into the facet joints. Now, this patient received the IV fluoxetine and oral rifampicin and moxifloxacin, and over a period of 3 to 4 weeks, there was clinical improvement observed in this patient. There was no diagnosis, no biopsy done in this patient. The patient directly received the antibiotics and there was clinical improvement. This was the patient. Second patient was a 35 years old male patient who had a history of L4-5 microdiscectomy and laminectomy in 2015, revision surgery in 2016 with post-surgical CSF leak. He received a epidural corticosteroid injection some time back, and he was offered bone marrow concentrate intradiscally at L3-5 and L4-5 levels. This patient also received the IV antibiotics, but there was no addition of antibiotic in the contrast in this patient. There was no culture. So the post-injection patient developed severe back pain, and on MRI, you can again see at the L3-4 level there was a end plate edema that can be seen. There's no extension into the paraspinal space. Now the cultures were taken and they were negative for any bacteria. The CRP and ESR levels were 49, 4.9, 6.3 was the WBC levels. There was history of a fever. The patient was receiving cefepime, ceftriaxone. However, there was no clinical improvement that could be seen in this patient. So infectious disease physician was consulted, and actually he started steroids in that patient, and within 24 hours of starting steroids, patient observed a clinical improvement in pain. Now the third patient was a 34 years old male patient. He did not had any history of prior surgery. There was the patient received leukocyte poor PRP injections twice intradiscally. He was also offered BMC injection at 2 levels, L4-5 and L5-S1 level. Patient also received IV antibiotics. However, there was nothing added in the contrast. This patient actually developed discitis at the level of L4-5. This is his MRI. So these are the 2 levels which were injected, and we can see the edema in the. We can see the edema in the L4-5 level. Actually, cultures were taken, and it came positive for QT bacterium acnes. Now, the ESR and the CRP levels in this patient were 41 and 82. WBC count was only 7.3. This patient also developed fever post-injection. This patient received IV ceftriaxone and oral amoxicillin. But actually there was not much significant improvement even after the antibiotics, and there was a consideration for surgical fusion in this patient. Now, according to this review or study, it suggested a complication rate of around 0.74% for intradiscal mesenchymal signaling cell injection and 0.5% for intradiscal PRP injection. Now, the reasons for this potential increased risk post-injection, what have been postulated are: first thing is that whenever we are injecting or we are preparing the platelet-rich plasma on bone marrow concentrate, there is increased handling of the injected. It may allow for the possible contamination. Although the systems that are being used are closed systems, but definitely there is a chance for contamination. Second is that the bone marrow aspirations that are being done are done with a large bore needles. 11 to 15 gauge bone marrow biopsy needles are used, and theoretically, the larger the size of the needle, the surface area maybe it will be also large, and there will be higher risk of contamination despite sterile techniques. Another concept that increases the risk of this infection is the concept of intradiscal microbiome. So what they are saying is there appears to exist a complex microbiome within the intravertebral discs with differing distributions and diversity of bacterial populations in healthy disc versus in disc with degeneration and herniation. So this suggests a possible disc biases theory. So whenever we are injecting anything or into the disc, there is an imbalance and overgrowth of these innate microbiome already present within the disc. Now, how this can be further confirmed? There are reported cases of spontaneous discitis. So definitely this supports the theory of the intradiscal microbiome and the disc biases theory or the imbalance following the injection. Now, second, one more thing is that it is possible that the bone marrow space within the pelvis also harbors its own unique microbiome, therefore allowing the transfer of dormant bacteria into the discs during the DMC injection. Now the second patient that we discussed in the case, in the 3 cases that we saw, the second case actually on CT guided biopsy and culture, no microorganism could be confirmed. And that patient also got better after the steroid injection. So that raises the possibility of an extreme inflammatory reaction to this injected rather than an infection. Now, what to do if you are suspecting infection? So it has been observed that the patients in whom infection was identified early went on to do reasonably well clinically and did not need surgical fusion. So early identification is very important. Imaging and imaging alone is insufficient for diagnosis. So even MRI is second sensitive. Most sensitive, what they say is the FDG PET scan, PET CT scan. And what they have said is the imaging alone is not sufficient. We have to do the CRP levels, we have to do the ESR levels, we have to monitor them, and we have to also see the patient clinically, and accordingly we have to diagnose. It is also recommended that the patient undergo a CT guided biopsy before initiating antibiotics and coverage with a broad spectrum antibiotics such as ceftriaxone while awaiting the results. In addition, because overgrowth of this Cutibacterium acnes may be the causative agent in many of these cases, cultures need to be performed for at least 14 days under both aerobic and anaerobic conditions. So it is not, because it takes time for growth in the culture. So it has to be cultured for 14 days. Now, what are the safety considerations? First is addition of antibiotics effective against Cutibacterium acnes to the contrast dye. It can be followed, may further reduce the risk of the intradiscal infection, and it should be studied to determine dosing as well as the potential toxicity to biological. So we have to see what are the benefit and if it is affecting the action of the biologic injected also. Now, gentamicin, according to the authors, it has demonstrated preserved biological activity when added to the iohexol in vitro, and therefore may be of value in setting of biologic intradiscal injection. Now, antimicrobial properties of leukocyte-rich PRP preparation may have the potential to suppress the intradiscal infection or dysbiosis, as this is the only intradiscal orthobiologic with both double-blind randomized controlled trial and long-term outcomes. It is currently the preferred injected for use in the intradiscal space in a practice. Now, the limitations accepted by the authors are, first is that the reported infectious complications are from single case reports and do not reflect the number of uncomplicated procedures performed by those clinicians and practices. This again highlights the importance of a larger multi-institution review to identify a more accurate complication rate for these procedures. Now, the majority of the studies included are case series with a retrospective view. Some patients may have been lost to follow-up and therefore making it difficult to fully ascertain the rates of complications. Review also does not include the studies of allogenic orthobiologic injections, which are emerging as the promising treatment. Now, in critical analysis, definitely I find that there is not a single RCT is included in the review, maybe because of the RCTs in allogenic include the allogenic injectates. There is no comment on other maybe significant factors like the epidural steroid in last 3 months. Next is there is no actual recommendations given by this. So they are only talking about, they have only reviewed, they have not actually given any recommendations about how to use and what are the precautions that should be taken. Then the selection of case 2 for biologic intradiscal injection. So if you read the article, in the article in description, what they have written is the patient was actually referred to the author with a suspected discitis, and how that patient was offered a biologic intradiscal is a question that has to be seen. So that is controversial. So the take-home message or the conclusion is that discogenic pain has been historically a difficult condition to treat. Although overall very safe, cases of spondylodiscitis have been reported following these injections. Multi-center survey is needed to more accurately quantify the true incidence of these complications. At present, basic science data support the use of leukocyte-rich PRP for safety optimization when performing orthobiologic intradiscal injections. Thank you.
Thank you, Dr. Sanjog. Sandeep sir, would like to have the questions now, or can we take them later in the end?
We can later take the question later. No problem.
Dr. Rupali, you can now start your this presentation. I just put up your screen slide. Yeah, I can see you. Then start sharing your screen. Yes, so please put up your CV slide. I'll just introduce you. So I cannot see your CV slide, I think. Can you make it full screen?
It is full screen, so I have put up the slideshow.
Okay, I think then we need to just share again. Dr. Sanjog, can you see full screen? No?
No, can't see the full screen.
Okay. So, Rupal, can you try once more?
Yes, sir.
Yeah. So make this full screen. Are you on a Mac?
No, sir.
Okay. Thank God. That's I don't have Mac, so I find it difficult to troubleshoot. Good. Okay. No, we can't see it. Maybe you can go on slideshow. Okay, you can see it full screen, Rupali.
Yes, sir. I can see it full screen.
Okay. No problem. So then what you do is go in the Zoom and start a share again.
Okay, sir.
We try once, otherwise you can present like this. It's okay. We can make out. Yeah, I can see full screen now.
Yes.
Okay, there is a big window in the middle. Can you hide it? I don't know what is it.
I also have noticed.
Okay. Okay. So there is a, you can maybe press the okay, this is a, yeah, okay, good. So now it's okay. So Dr. Rupali is DNB Anesthesiology. She's done her SRship in Tata Memorial Hospital in Sangrur. She's done her AORA fellowship in regional anesthesia and acute pain management at DMC Ludhiana. And she's also done an observership in pain medicine at the Mumbai Pain School. So over to you, Dr. Rupali.
Thank you, sir. In the series of the Journal Club, we are discussing the regenerative medicine section, and today I'm presenting a case report which has been published in the Journal of Regenerative Medicine. The case report was published in 2019, and this journal has an impact factor of 3.2 as of 2021, and the authors, Nicholas R. Betty and et al., belonged to the Regenerative Sports Care Institute, New York, USA, and Department of Rehabilitation and Human Performance, Icahn School of Medicine at Mount Sinai, and Hospital of Special Surgery, New York. They have published this report of spondylodiscitis due to QT bacterium akinase following a lumbosacral intradiscal biological therapy. So as we know, lower back pain associated with degenerative disc disease is extremely common and is affecting a large population and also increasing the disease burden as measured by Delhi. So targeted intradiscal biological therapies are a non-surgical treatment options amongst many. So autologous treatments like PRP, bone marrow aspirate concentrate, lipoaspirate, and other molecules act as cellular therapy, scaffolding, and immunomodulating, also nutritional physiological support to repair this disc degeneration. So ideal intradiscal therapy would inhibit the ongoing disc catabolism. It will stimulate the repair of the disc and also improve the biomechanical status of the vertebral motion segment. Intradiscal PRP has been shown to improve functional outcomes at 6 months through 2 years without complication or adverse effects reported till date. And also the antimicrobial activity of the PRP is also studied well in multiple studies, also in surgical and implant-related infection to prevent implant-related infection as well. So the aim or the objective of this publication was to reconsider the antimicrobial effect of the PRP, also to see the role of Cutibacterium acnes in spine infection, and also to find an ideal treatment protocol for intradiscal biologics in order to minimize morbidity and function and improve the functional outcomes. So in this case presentation, there was a 40-year-old woman who presented with a severe chronic discogenic low back pain with buttock pain, which was since 2 years, which was not responding to comprehensive conservative treatment. So as a part of a diagnostic and therapeutic workup and a treatment plan, the fluoroscopic guided lumbar discography at L3, L4, L4, L5, and L5S1 levels was performed using a double needle technique. As per the authors, the sterile technique was practiced, including the use of sterile personal protective equipments, drapes, and covers, sterile skin application with 10% povidone iodine, followed by 2 applications of sterile package with chlorhexidine gluconate and isopropyl alcohol applicators were done. At L3, L4, and L4, L5 levels, then there were normal nucleograms without evidence of annular disruption were found. But at L5S1 level, there was a grade 3 annular fissure with 1 cc of contrast and had concordant symptoms. So 60 cc of peripheral blood was obtained from the right antecubital fossa, and the PRP was prepared using the M-site protocol to provide 3 cc of PRP. This protocol typically gives a high concentrate of the platelets and a low neutrophil count and minimal to no red cells, and they did not use any activation method. So she underwent the injection of 2.5 cc of PRP at L5S1 level with fluoroscopic guidance under a double needle extrapedicular technique as under a monitored anesthesia care. So a contrast agent, Omnipaque, was utilized without intradiscal antibiotics. They did not add any antibiotics to the contrast. Sterile technique was practiced throughout the entire procedure and handling of the PRP, and there was no immediate complications, and the patient tolerated the procedure very well. But later on in the long-term follow-up, after a few weeks, the patient started having back pain with night sweats and decreased mobility. MRI was performed at 10 weeks post-procedure, and there were findings concerning discitis. And also the acute phase reactance of the patient was also increased. ESR was 9 millimeters per hour, and CRP was 39.3 milligram per liters. Then she was admitted for the tertiary care center for further workup and treatment. A CT scan and an MRI showed the signs of active infection. They revealed destruction of the end plates at L5S1, and lytic bone marrow lesions were also seen at L5 marrow space, and reactive sclerosis at S1 was seen, but there was preservation of L5S1 disc height. MRI also showed corresponding findings, and there was no epidural or soft tissue abscess. In the treatment protocol, they performed L5S1 disc aspiration and biopsy, and they found bloody and purulent fluid, which grew gram-positive bacterium, QT bacterium akinase. After a discussion of possibility of skin flora, as C. akinase is a normal skin flora, and potential utility, the patient declined for a repeat biopsy. And the patient was treated with the antibiotics, ceftriaxone 2 grams for 6 weeks, and through a periphery inserted central catheter. So patient improved after the treatment. In the follow-up, labs were ESR reduced to 2 and CRP to 4.1. And the repeat CT also showed no signs of active infection. And clinically, she remained afebrile, back pain persisted, but was less severe, and her functional status improved. Follow-up medical and surgical evaluation at 1 year post-injection concluded that there was no longer a sign of active infection, and no spinal instability and no need of spinal fusion was found. Infectious complications following discography are very, very uncommon that have been reported. So only 0.016% on examination and 0.0054% otherwise. Most common agent which has been found is Staph aureus, more than 50% of the cases. Other agents have also been found. C. akinase is actually a normal flora on skin, oral cavities, as well as has been found in the intervertebral disc of asymptomatic patients as well. It is a gram-positive rod-shaped bacterium, and has also been pathogenically related to infections of bones and joints, surgical implants, vertebral osteomyelitis, and pyogenic and non-pyogenic discitis and spondylodiscitis. This species and its subtypes are under-recognized pathogen in spine infections, and hence there's a controversy in this case whether it was a contamination or it was pathogenic. Spondylodiscitis following the use of biological therapy is previously not reported, and IBT has a better profile compared to other treatments such as oral corticosteroids, epidural steroid injections, and surgery. However, this case highlights the potential morbidity associated with the biological therapy. So for biological therapy, we need to have vigilance in sterile technique, including biological injected preparation, also risk stratification of patients who might be on a higher risk for infection, and also protocol optimization based upon better understanding of all the pleiotropic effects of the PRP, of all the components of the PRP, as and also its interaction in vivo with the intervertebral disc environment, as Sanjog said also mentioned, the normal flora of the disc. In the context of C. akinase, it is a different pathogen, as because it can resist phagocytosis and it persists in the macrophages, and it mediates the inflammatory cascade, and also exhibits cell adherent properties and has a role in the biofilm formation. So hence the preparation components and antimicrobial activity of PRP needs further study with regards to C. akinase. So primary technical and procedural considerations of biological therapy include the use of intradiscal biologics and optimization of components of the PRP. Traditional provocative discography often includes the use of intradiscal, intravenous, or both antibiotics. Intradiscal antibiotics are often used with the contrast medium. With the use of orthobiologics and biological therapy, there is evidence that the antibiotics and the contrast affect the viability of the cells and the biological activity. So it has to be used judiciously, but also also, by not using the antibiotic, we are also increasing the risk of or the chances of infection. So we have to balance and risk stratify the patient as well, and also the components. So better understanding of the role and route of antibiotics in preventing C. acnes, spondylodiscitis, and its effects on treatment outcomes needs to be evaluated. At last, the role of each component of intradiscal biological injectate in healing needs to be understood. So the PRP has antimicrobial properties used in clinical application. So it has been attributed to the platelets, also to the alpha granules containing thrombocytins and leukocytes and plasma peptides. So there have been several studies which have studied the leukocyte component of the PRP, and they have said that leukocyte concentration has been correlated to the antimicrobial effects, suggesting it may be the plasma or its component rather than, and also some studies say otherwise. So, however, other research concludes only high concentration of leukocytes inhibited staph epidermis growth. So, when treating the intervertebral disc, Wang concluded in their study that the PRP activate inflammatory and catabolic effects on nucleus pulposus, and therefore recommended a leukocyte poor PRP. This inflammatory response may mimic a non-pyrogenic discitis, which has been anecdotally seen following IBT. By improving our understanding of the injected mechanism of action, we'll be more able to devise better treatment options. And the current case highlights the need for better understanding of the infection risk assessment with the biological therapy, as the utilization of these treatments is increasing day by day. Additional studies are needed to learn whether or not different types of PRP preparations have greater potential at protection against C. acnes. And in addition, further studies are required to see if the intradiscal or intravenous antibiotics at the time of IBT will adversely affect the clinical outcomes. The limitation accepted as a single case report, which is a weak evidence. It is a single case report, and it did not discuss the other possible PRP protocols and that are available, and different antibiotic protocols that could have been used in this case to prevent this condition, and no detail. This gave a case report, but it did not specify how they could have avoided this complication. So the take-home message here is it is a rare complication. Very less reported cases have been seen with C. acnes causing spondylodiscitis, and IBT is increasingly used these days. So we need to further evaluate all the possible morbidities of these procedures, and so we have to, there's no ideal PRP preparation or an antibiotic protocol till date which has been recommended. So this case report also pushes us to find one so that such complications can be avoided. Thank you.
Thank you, Dr. Rupali. Now I request Dr. Sandeep to kindly proceed with the discussions. If there are any questions, for those of you who are listening, please type in the chat box and we'll be very happy to discuss them.
Thank you, Dr. Sidharth. Actually, both the speakers presented very well. But few things I think regarding the studies presented here, both the speakers have already identified the limitations of the study, so I don't really have much to talk about the studies themselves, but I think something need really brainstorming. First of all, from the first study, the reported incidence of infectious complication has been found to be 0.5%. So if we look at that incident, it is much higher incidence. It is comparable to the surgical interventions. Okay, so that means that out of 200 patients, one patient will get infectious complication in the case of discitis or epidural abscess. So if we compare this incidence to our epidural and spinal interventions like placement of epidural and spinal needles, it is much higher, because in spinal and epidural, the incidence is 1 in lakhs, like 1 in 3 to 5 lakhs. But here it is 1 in 200, that is much higher and is comparable to the surgical intervention. So we have to think in terms of regard of benefit. So how much benefit we are going to give to the patient, because as we increase the number of procedures, so the number of complications, the number of patients who will present with the epidural abscess or discitis will also increase. So first, because at the seeing the current level of evidence, we can see that it's level 3 or level 4 evidence. So I think the onus is on the researchers who have to find the actual benefit of these procedures. Actually, only then we can justify this infectious complications. Because if we are able to provide much better relief with interdiscal biological therapy, as we discussed, so we can go on taking up more patients for these procedures. So in the meantime, I think we have to really protocolize the antibiotic, whether it is IV or interdiscal, to minimize the infectious complications, as far as like a common sense goes. Okay, like we have to use the antibiotic. So I think if I have to take any patient for interdiscal biological therapies or PRP injections in interdiscal, I would like to have IV antibiotics and interdiscal antibiotics as well. So, but at that point in time, I do not know whether this use of interdiscal antibiotic will hamper the beneficial effect of interdiscal biological therapy. So I think that needs more studies has to be done. That's from my side. Any audience want to put any shed light onto this topic? Most welcome.
So I think there are no questions. So we will, Dr. Rupali, Dr. Sanjog, do you have any questions or comments?
Basically, according to me, we have to, as Sir said, we have to actually see the risk to benefit ratio in these kind of procedures. And we definitely have to do research with lots and lots of patients to actually find out the rate of this, the incidence of this complication, and then it can be generalized. It can be a part of the guidelines, because discitis is very difficult. Once for us as a pain physicians, if we get a discitis, then for other specialties, okay, not okay, but then also it's kind of okay. But for pain physician to get discitis is a difficult thing, and it sticks on with you.
Actually, when I think 5 years back, I intended to study interdiscal PRP injection. So when I applied for ethical clearance, the ethical committee asked me to deposit 80 lakh rupees before I start doing research on this. So I dropped that idea actually. So they quoted that it is such a high incidence. Even one patient got complication and he went into disability. Who is going to pay this? So this is have to be taken into consideration. And I don't know, I'm not doing interdiscal PRP. In my experience, I'm using PRP only for musculoskeletal conditions, like for shoulder and knee joint. Interdiscal therapies I have not done. I don't know you, but Sidharth, are you doing this?
No, sir, no.
Yeah. So
I'm quite scared of this because I am doing a lot of other interdiscal procedures, and even I get discitis in those patients. So I'm quite scared to put PRP and all these things. That's why we there was a lot of talk about these. So I would be, at least I will not like to do this procedure in any patient out of the probably other than the patients who are registered for a trial already, officially registered for a trial, because then it will be, I feel it will be quite unethical. Same here, Siddharth. But definitely there's a lot of interest in this subject, and research should be done. Those of us who are interested should make efforts towards doing it, start a trial and maybe register patients, explain to them the risks and benefits. Now we recently have got allogenic stem cells also available, and I'm sure in future we will have stage 4 trials for them in the disc also, because the results are good in the knee. So maybe they will like to try it in the disc as well. But definitely these, knowing more about this will have a good effect in, preparing ourselves for the worse, I think.
Yeah. I also would like to say one more thing that I remember when I went for ethical clearance 5 years back. They asked me one more question, that interdiscal space is a closed space, okay? And if you put growth factors or stem cells into that space, suppose it went out of control, okay? So so what would happen? Suppose you are putting in a knee, it went out of control, no problem. You will the surgeon will aspirate it, or this patient will lose one of his limb. But if anything happens in the interdiscal space, patient will went into disability. So, and I think this is a serious concern. So I think we have to think that way also.
So I have one question. Actually, we are doing intradiscal procedures like ozone, or there are people who are injecting steroids in the intradiscal space for same discogenic pain. So are there any studies which are, or there studies which have identified the incidence level of discitis in those kind of interventions? Because we are talking about incidence of discitis in PRP or biologics, then we definitely should compare.
Maybe we can compare that.
Yes.
So maybe we can compare incidence of discitis. There is definitely papers on discography discitis, incidence of discitis and discography. I'll just maybe we can just check on that, because that's a common entity. Even one of my patients, after discography, they went into discitis, and that was quite a nightmare for me. So it's very it's not uncommon. And as Dr. Sandeep has mentioned, that this is very closely mimicking the surgical thing. Actually, surgical is a slightly higher, maybe 0.1 to 0.5 to 1.5, or in some cases even 3%.
Up to 20% incidences.
Yeah, so in some cases it's very high, but definitely as compared to most of us are anesthesiologists, and we don't take failure for we don't like to fail. So I mean that's we have very extremely high standards, and very it's the least complicated stuff. Although we are exposed to most risk, the indemnity insurance is the highest in our case. The surgeon has a lower premium than us, of course. So, but maybe this is inherent to our branch, so we like to, but that's why we are discussing all this, so that these points can be brought forward. Okay, meanwhile, there is a question here by Dr. Suresh. Do we need to think more about better sterile way of PRP preparation to what? Of course, the problem with PRP is still there is no standardization, there is no generalization. And there are like n number of companies, n number of even when I ordered or wanted to order in my when I started my practice, I wanted to order the PRP equipment, and the owner of the hospital and also the dean and the medical student, they asked me that PRP can be made in the blood bank, so why don't you take that PRP, and you can put it anywhere, everywhere. So the thing is that the differentiation, the difference between freshly prepared versus open system, closed system, all this knowledge is like quite low. And in the absence of standardization, it's very difficult to make out what is what. In fact, many times we don't know what is what. So my rule of thumb has been, I used to do a CBC. So I prepare extra PRP, and I used to do a CBC as a quality control measure. But that's also a very rudimentary way of finding out. Unfortunately, the kind of kits which are available in markets like United States, they are certainly not available in India, and the cost is extremely high, like 10 times And as a result, the quality is quite low. Most of the products which we are using are made with low grade materials, and in fact some of them are even Chinese. So that's another cause of concern. And for that very reason, because I know all this, so I will never ever try to put this in the disc. So I mean, I get scared even while putting it in the knee. So it's very difficult to put it in the disc. So definitely we need a more sterile way of PRP preparation. Most of the market is preparing PRP for regeneration of the hair. And when I started this thing and I wanted to promote, so I started putting PRP everywhere, and then people started calling me, sir, oh bal, you grow hair and all that. So it's quite common, and most of the kits also which many of us are using, they are actually meant for skin uses, and skin is very different than joint. It's a very richly vascular area where you don't have a risk of as much risk of infection probably or you are not that scared. Cellulitis is kind of a rare this thing complication. Although we see incidences of people dying from that as well, but quite rare as compared to, and most of them are untrained. So I think Dr. Suresh, your point is well taken. Great. So I think thank you all for the nice discussion. Sandeep sir, any last words? Dr. Rupali, Dr. Sanjog, you want to say anything?
No, that was a very nice discussion, and it's an eye-opener for all of us.
Great. So thank you for joining in, all of you. It was a great topic, and this season we are discussing the regenerative procedures for spine pain, and this is the season 3. For the next few weeks now, we'll have a kind of a holiday break, and we'll resume soon in January mid or maybe end. This season we had a new time. We had grouped some special topics, and we had some 2 faculties with 2 papers, and of course the secret of getting things done is to act. So please join our mailing list, guys. The link is in the chat box. All the suggestions, comments, any future suggestions for topics for the future seasons are also most welcome. Please write in to me, and I will be happy to talk to you, share with you at mumbaiPainSchool@gmail.com. So with these words, thank you very much. See you soon. And until then, happy learning. Bye-bye.
Thank you, Sidharth. Thank you, everybody. Thank you.
Thank you.
Thank you all. Thank you.